Good afternoon. My name is Kevin Patterson. I'm a vice president with Indogene and Strategic Initiatives, and I'm excited today to be moderating today a panel really discussing how technology is going to really start to influence our conversations and how payers start to view the marketplace and what they're going to do as we go through this. And it's a conversation where I think many of my clients have always come and saying, how is this evolving? How is this going to change the way we communicate? And it's not just between payers and manufacturers. It's how we're going to deal with the marketplace. It's with patients, it's with payers, it's with policymakers. It's how we're going to analyze data. And I'm very excited to be a part of this panel and facilitate this through this next 45 minutes with you. I'd like to introduce first my compatriot, Dr. Bill Lowe. Bill, do you mind giving a 2-second introduction on yourself?
Good afternoon, everybody. I'm Bill Loeb. I'm also a vice president here at Indogene. I've had the pleasure of working with Jeff and Marcus as a part of our PAO panel over the years, and it's my pleasure to be here today to support the group in this discussion that I'm excited about.
Thank you, Bill. First, I'd like to introduce Mr. Jeff Dunn. He's with Cooperative Benefits Group. He's been working with us for many years in terms of offering insights as we go through this and been a valuable part. Jeff, do you mind giving an introduction of yourself?
Yes, thank you, Kevin. So I'm a pharmacist by training. I've been in managed care for now 23 years. I started out at a health plan that was part of an IDN, and then left there and co-founded a transparent pass-through PBM, and that was acquired by a larger PBM, and then spent some time at Haven, and then now have co-founded another PBM, a Cooperative Benefits Group, which is a transparent pass-through PBM focusing on net cost. And I'm looking forward to this conversation. Kevin, looking forward to working with you, and also to Marcus. I've known Marcus for a long time. Marcus is one of the smart guys in our industry, so this will be a great conversation.
Thank you, Jeff. Marcus, that's a great introduction into you. Do you mind providing a little more background for our audience?
Well, thank you again for the opportunity, and thank you to everybody at the Indogene team, and quite an introduction from Jeff. I have a lot to live up to, and I've known Jeff for a long time, and I always joke, Jeff should be on the Mount Rushmore of managed care. I've been in managed care for now 33 plus years. Hospital-trained pharmacist, was a director of a cancer center. I've been in integrated delivery systems, health plans, PBMs. Academia, I still teach pharmacoeconomics at the College of Pharmacy as an adjunct faculty member. Was one of the early people at ScriptSave. We sold the company to MedImpact some years ago. I spend a lot of time in trade, clinical, digital strategies, specialties. So keep really busy, and really, again, looking forward to the conversation today.
Thank you both so much for being here. I'm looking forward to this conversation. So I'm just going to jump right in because I know our audience is really interested in some of these perspectives. And I wanted to start a little bit from a nostalgic point of view. We take us back 5 to 7 years ago, and we think about where we are today in the middle of this technology revolution. So you see, we've come through COVID. That forced some changes in the way that our constituents and key healthcare providers change and interact. What are some of these key things that you think have really evolved for the last three to 5 years, and how that's affecting the way that you're starting to conduct business and communicate with their key partners? Jeff, would you mind taking this question first?
Well, I think the first part of that question, around COVID and other things that obviously have been going on in the last 5 years, the most direct answer to that is it really kickstarted this technology boom. And a lot of that was telemedicine. We saw, a significant, obviously, shift to remote. People still had conditions and diseases that needed to be treated, and so it had to be addressed. And so that just accelerated that movement towards alternative ways to interact with patients. It also, I think, changed a lot on our side. We were always kind of come into the office every day, kind of strategy. And, now we've had to adjust on our side as well. So it's not just, talking to our clients and our customers and our partners, but it's how we interact internally. So, we've gone to kind of a hybrid model. So we've had to react to that. But I think the bigger things that we've seen coming out of COVID, the biggest thing, and Marcus, I don't know, how you feel about this, but when I talk to clients and customers and employer groups, it's all about drug trend and pricing right now. And so we saw we saw quite a bit of a dip in drug prices, in the year 2020. But since then, in the last 3 years, we've seen a significant acceleration and trend in drug pricing and drug increases. And 99% of the conversations I have with my clients are around that. Is how do you help me address what is going on with that? And I was at a conference a couple weeks ago in Florida, a payer conference, and we saw some statistics. The average cost of a cancer medication right now is $300,000 a year. And if you look at that across all of drug pricing, the average cost of a drug right now, including everything, is $150,000 a year. And that's doubled in 4 years. And if you go back, 15 or 20 or 25 when Marcus and I started, we're talking 1,000+% increases in drug prices. So it's not sustainable. And there are reasons for that. Obviously, rebates and whatever, right? There's a bunch that goes into that. But that's, the drug trend and how we work internally and how we communicate people has fundamentally changed in the last couple of years. And we're having to, figure out a way that this is going to be a sustainable model, and we're going to have access and affordability for our patients.
I couldn't agree more with what Jeff said on where this trend is going, right? And rather than, going on about drug pricing, I think the flat pricing has been part of the environment, but what we've seen is common chronic diseases that we were used to seeing $40, $60 per member per month are now $1,200, $1,500, $1,800 per member per month. And it's also not just the drug pricing that we're seeing that's challenging right now, it's the benefit design. A catastrophic high deductible benefit design. As much as our, pharma partners like to complain about managed care, copays have been a blessing for a lot of pharma companies. It's obfuscated price. Now our members show up on January 1st in a high deductible plan, they see a $500 eye drop and they get challenged. So what has that done? I agree with Jeff on COVID where we've had a flex. It's been a blessing in a lot of respects. We can hire talent from all over the country and we don't have to have everybody living at headquarters. So I think it's been a great thing for us in a hiring perspective. I think two things are challenging. One is we need to empower patients at the point of prescribe. I think being a pharmacist, we always try to think of the point of dispense, but I think where we really need to start inserting these tools and technology and stress is at the point of prescribe, have tools for physicians and patients to engage their benefit design and make sure that care that's getting prescribed is affordable and makes sense for their benefit design and the formulary. I think that's, at least I know where we're working a lot. I think the next is, I think we overlooked this, is I saw another interesting stat at a meeting just this week that physicians are spending more time, hours at their computer than they are seeing patients. I think physician burnout is a big deal. I talked to pharma a lot about cool digital tools. And I said, first of all, patients get app burnout. I can't put an app of every disease and every drug on their phone. I need a holistic, centralized, white label app. 2, all that cool information going to the doctor. My internist, I think, sees 13 different health plans and has 900 patients. Can you imagine the email overload and text overload at the end of the day? So I think right now I heard a futurist say we're at a Gutenberg moment in healthcare where we have got to really start to hunker down and decide if with the tools that we have, how do we centralize it, make it clean, portable, and as people move to different jobs and plans, they don't have to keep re-engaging new tools. It can be a platform. Hey, can I just kind of jump into that, just add on to that? Marcus, brought up a couple, great points. I think that's where technology can help with the efficiencies. And I'm sure we'll get into this on how this is applied. But, it's the information gathering. It's how we package that to get back to, practicing medicine and not, wasting time in operations and being more efficient in how we gather information and communicate information. But I also think the other important thing that he mentioned, and I just want to kind of jump in on is hopefully, either technology and pressures and legislation and other things can actually help address one of my soapbox items that I always talk about, and that is, shared risk, right? So right now, unfortunately, healthcare is very siloed.
And if you follow the dollar, it ends up, either the health plan or the government or the employer, and it's really kind of one-sided. And so that's why we end up doing a lot of things that I don't really love, and that could be, patient assistance or accumulators or international sourcing or all these kind of things, which again, negatively impacts the patient, I think, in the long term, and makes it really hard for them to navigate this large, cumbersome healthcare system we have. And so, if we can kind of address that and break that down, and share risk, because we're heading towards an affordability cliff, and it's an accessibility issue for our patients and our members. And if we don't do a better job of that, then it's so confusing and so burdensome that, regardless of what we do, patients aren't going to be able to take their medications.
Sure. I think both of you stressed, sorry, Kevin, I'll jump in. Both of you stressed that the future of communication might change, right? It's a communication to patients and providers about benefit design, about options, about a number of issues. And also the way that you may be able to gather that information has also changed with the AI and the large language model. Have you done any exploration with regards to adapting some of those technologies to have chatbots or other things for patient interactions, disease-specific interactions, anything like that?
And we're looking right now on some product launches that are AI-based, and it's a benefit design really specific. So when a patient is in a physician's office and that point of prescribe happens, I think we forget a lot. And when I speak with my manufacturer partner, it's the same, that it's not just the drug selection and the formulary, it's site of care. And if you're sitting there naked in your $7,000 deductible with 20% coinsurance, sometimes, and you don't have a stable, let's say, living opportunity, let's say you're moving from house to house and you're in between jobs, like Jeff was saying, sending someone an $18,000 bottle of pills in the mail to some address might not make sense, right? And AI tools can help. Or someone will come to me and say, this is great, it's a once-a-month sub-Q syringe for a 67-year-old person. And I'm like, can they inject? Do they have the dexterity to inject? Do we need to coordinate home health? I think the thing that Jeff and I have probably been talking to each other about for decades now is this disparate databases and the silos that Jeff referred to, that to do that longitudinal pharmacoeconomics has been challenging. I mean, if you have 150% churn in Medicaid, or you have 9 health plans in 12 years, real pharmacoeconomics is tough. I think some of the things that we're looking at AI is bringing those databases together, a more trustworthy way to look at value, like Jeff was referring to earlier. Is that drug providing long-term value? Are those cost offsets real? Because right now, it's been a real challenge to put a pin in some of those numbers. Yeah.
I think,
And
go ahead.
Oh, Bill, I was going to say or Kevin, we look at chatbots. We have chatbots, they play a role. Part of me, I have a love-hate with those. When I call into customer service places and it takes me 50 prompts and 20 minutes to find somebody that can actually answer my question, it's super frustrating. And I think that's frustrating for our patients. And so they play a role. But I think when you get into, some care management issues and some other things, there is clinical judgment, and there is a need to talk to people. And so how we find that middle ground and leverage those and build on top of those is going to be super important. But, we also, I just pulled up a list of things that our IT department is working on, and it's huge. I mean, it's how we use AI in these things, and it's anywhere from medication adherence prediction to drug interaction risk assessment, to drug shortage prediction, to cost prediction on budgets, and doing a better job of actuarially underwriting things so we can work with clients. Again, a side effect, probability prediction. It's all kinds of different things. We have a whole laundry list. We'll get into some of this, I'm sure. So it is fundamentally, changing how we're addressing things. I think we're still kind of very early on, and we're trying to figure this out. But this is going to come fast and hard. And technology increases. Yeah,
We're at I know Kurzweil always likes to say the word exponential, but if you even go back 24 months, this has literally been exponential jumps in what we're doing. And I think anyone who's ignoring it is going to be left behind. And I'm going to go back to, I don't know what Jeff's looking at. There's so many new technology companies cropping up, digital technology companies that are, again, empowering the patient, right? And again, if you put a patient in a position where a decision has to be made now. I think they're so confused about what it's really going to cost them. They don't want to see 4 weeks after an incident that they get a $1,300 bill that didn't apply the deductible because they were an out-of-network provider. I mean, hopeful that some of these AI tools can alleviate some of that administrative burden for the offices, the patients, the employers, and like Jeff said, get people back to practicing clinical medicine.
Yeah. You've mentioned three components in this discussion that I'm going to kind of call out. Cost, obviously, speed, and information overload. Those are if I put them in big buckets, that's where they come. A lot of our clients are asking, how can they partner with you to alleviate? I'm going to take cost to the side because that's always one we can go down, but let's focus on speed and information overload from either the health provider's perspective and or the patient's perspective. What are some initiatives that you think would be ideal for you to maybe partner with manufacturers? You mentioned consolidated applications, other things, and they don't have to be specific items, but real initiatives that you think are important that can start to facilitate this change that's coming. And this information overload is really significant. That's something I hear from patients and from our provider informants as well. So what are some of your thoughts on that? Marcus, let's start with you on that.
Yeah, not to be negative, but what I don't want is, and what has been sort of commonplace, I don't know if Jeff's seen it too, is like, here's our tool and you load the app on, and I go back to, and then I got a lobby full of people who have their app and their tool, and then we have our app, and their pharmacies have an app, and their specialty pharmacy has an app. We need to streamline this. All of this needs to be able to be put into a central hub of a tool on a patient's phone. I've said this to about 50 pharma companies. If I'm traveling today from San Diego to New York, I don't have a San Diego weather app and a New York weather app on my phone. I have a weather app. And that's where we could really work with pharma and try to find sort of, best in practice tools to centralize this information. Again, if I have 4 or 5 disease states, you literally could have 20 different tools on your phone trying to figure that out. Pharma can help us, at least talk to some technology companies, I think would be a start, but not just to come in with your branded tool and stick it on the phone. That's a mistake. Or go to the employers and do that too, because then, if you have 4 drugs in a therapeutic class, you could just see how this can just get pretty unwieldy fast.
Yeah, I agree. And I'll even extrapolate that, to our care management teams and other things that we're doing on our side when we interact with patients. I mean, the honest answer is historically, we haven't paid much attention to those programs from pharma because exactly what Marcus said, there's too many, there's not integrated. Patients have more than one disease. We can't expect patients or, our care managers to have, a dozen programs up and trying to match that as they're talking to people. So, but and the other thing is, I guess that needs to be addressed with this though, is kind of the PHI component, if you want to call it that, for lack of a better description, because historically a lot of these things have been developed and the data doesn't go to the payer. It goes to the provider and the patient, and we're assuming they're using it. But if we can't get the data because, for whatever legal reason, that can't be shared with us. And so, therefore we kind of ignore it. But what I think is can change and moving forward is, how they help us gather, legitimate real world evidence and patient reported outcomes and things like that, getting data, this big data, going back to this big data comment that we talked about a decade or two ago, so that we have all of this information where, we can, be more productive, but also potentially use it in things like value-based contracting. I mean, that's where some of this information is going to be helpful, I think, is going back to my risk comment. If we have better information and we can actually execute on it and measure things that we haven't been able to measure in the past, we can have a better legitimate conversation about how we work together on pricing. And that's fundamentally going to address the things that we brought up right at the beginning. But I'll just going to wrap up by saying I haven't seen a lot of information coming from pharma yet in this area. I'm sure they're using this a ton in the background, around things like, drug development, and AI and study design and, running predictive analytics and all that kind of stuff. But I haven't really seen it translate to the payer, at least, publicly. But there's a huge opportunity But again, it's all around big data and data sharing. But again, Marcus is exactly right. If it's a one-off and by individual pharma companies, we can't use it. It's got to be more of a holistic approach that's integratable and simplistic. We can't make it more confusing to people as we go through this process.
Jeff struck on two really important things. One is the value-based contracting argument, which, again, academically, I find fascinating. Academically, I find really interesting. But in theory and practice, I don't know why we can't substitute the word warranty for that. And that's an opportunity. Another one thing I always like to say is if I buy a toaster and it don't make toast, I get my money back, right? Why can't a value-based agreement be that simple, right? If the patient discontinues for any reason in X period of time, then there should be some warranty, and money flowing back to the patients who are in these high deductibles would probably make some sense. But that is an opportunity. We have extraordinary HEOR academic institutions across the country. If pharma wants to invest in this AI way of gathering the data, so it provides a more believable way for us to extrapolate that. Because the challenge is for an employer who, let's say an employer owns 15 fast food, Kentucky Fried Chickens, and has 1,000 employees, walking into them and saying you're going to use a $1,500 drug and we're going to save an event in 10 years, you kind of can get a blank look, right? But if you can at least say that everybody's going to be on these products and there's a way to capture the risk, and as people flow in and out of your organization, you should be benefiting, and you can document that and warranty it, makes sense. But right now, I don't know about you, Jeff, you get a lot of blank looks when you tell people that drug A is going to save you a liver event in 15 years and it's going to be $2,500. The peer-reviewed published journal article, or a ICER value is just not going to sell it to an employer. I think this is an opportunity for pharma to really dig in on this and back that value equation.
Yeah, I totally agree. It's the long-term ROI, and maybe the other example there is what we're going through with weight loss, right? As a lot of people don't want to invest, that's just it, right? $15,000 a year for an event, maybe 20 years down the road, if it happens, and that patients are, they're not going to be employed there or anything else. But, even more short-term stuff, it's cancer. Let's say cancer is a perfect example where, you might not have to wait 20 years for an outcome. It might be within the next 6 or 12 months. But how do you measure an outcome in cancer in order to execute on one of these types of arrangements or contracts? And so that's where these types of models and this information gathering, I think, helps, again, moving more from the subjective arena to the objective arena, and making these executable. Because right now we don't have that data. We can't gather it. We can't measure it. You're right. It's a timing issue, but there are some shorter term opportunities. If we had the data, we could actually do this.
Agreed. Is there anything within your case management that you've talked about using technology from your side to manage patients to get the data that way through programs, like some of those diabetes management programs back in the day, right? That you could use technology now to track some of their behaviors and some of their outcomes, if you will, that you're
100%. Yeah. So, even like 10 years ago, we started some programs that looked at trying to identify and not label patients, but identify kind of, what type of patient they were. Were they like an A+ student that was going to listen to everything, or were they a skeptic or whatever, right? And that did kind of change how we reached out and interacted with them. Was it a call? Was it, technology-based outreach? How do we, need to educate them? So we started that a long time ago. That's pretty cool. But, again, with that is, I think payers are in a unique opportunity or position here because we do have data. We just need a better way to get that data in an actionable format. But we don't always have lab data. We don't always have, all the medical data. We have really good pharmacy data. So, again, using all of this data, it's again, this big data comment that I mentioned. If we could mine that better, there is absolutely a way to model that. And again, whether it's predicting which drug's going to work best for somebody and avoiding, the failures, or predicting drug interactions, there's all kinds of things that we can do, and we're close. It's getting there. But it's how we get it, and who's participating in this. And if we're all kind of doing our own thing in our own silos, it's going to be more difficult to do.
Well, the patient's phone, and even in Medicaid, right, a lot of plans support technology on the phone and hours on the phone. The phone is going to be the central hub for this data that we can pull. And, pharma can help there too. There's legislative things that we can discuss to try to get us all to agree that that may be the central hub. And that can actually then create those risk corridors. I think from a case management thing, we're looking at empowering the patient with those tools. Jeff mentioned, the GLP class. We did a darn good job years ago on smoking, but it wasn't gum and patches and pills. It was a holistic societal view on what smoking was and what it should not be. And I think that has to empower the patient to make those tools about their own metabolic health. It's not, these drugs are going to have the same failure rate as all the other tools, whether it's surgery or other drugs. I think it's not until you empower, and I think the word that sometimes in healthcare, even pharmacy folks like me kind of shy away from it, reward an outcome. I mean, not to fill the conversation with analogs, but right, I get a check if I drive safe, but are we rewarding people for really hitting hemoglobin A1C targets? Are we going to those tools in their hands to do that? I think that's going to be the next level of digital case management. I think Jeff struck it earlier. There's going to be responders and non-responders, A students and F students, and you can't manage everything the same, right? You can't approach every disease with a cookie cutter approach. I think that's where a lot of this digital technology is going to be a help.
And you were spot on. It's patient engagement is such a huge part of this. What we've also found over the last 20 years is, we can't tell people what to do. That's not effective. If they understand what's going on and we provide them the right information and they buy into the plan, it's much more effective. The challenge is, and I think Marcus just said it, is, via the phone or everything else is there's data out there that we need, that we can get. But the question is, how do we get it? And then there's legal ramifications of that. There's privacy, implications to that. So we need to wade through that. And I think that's going to be a huge issue with AI moving forward, is that privacy part. I mean, I don't want to say like Big Brother or things like that, but again, can we get it? It goes back to my comment about, the historical programs that Pharma presents to us. That data is geared towards the provider. That's not to us, but I'm the one that's managing these patients. And if for, privacy reasons, I can't get that data, I'm not even going to pay attention to it.
Yeah. And Jeff, you said it. I mean, patients are probably applying more wearables to their bodies today that's gathering healthcare information that payers do not have access to. If you have a hypertensive type 2 diabetic patient who's 45 and has a BMI of 35, and they are actually applying wearables, and self-purchased wearables, where's that data going, right? And again, you asked the question earlier, how can pharma help? No one influences better than a pharma, right? This is a time to start influencing legislative, whether it's digital tools and technologies, to at least create this database or ask patients to register this data. It can offset a premium if you do it. It's like Jeff says, it absolutely spot on. It's out there, but how do you claw that back?
Oh yeah, registries. There you go. I love when you said registries. That sparked it. I mean, there, right? Again, that's information gathering. That's how we measure, PROs to drive VBCs, all that kind of stuff. But we just need we need to tread carefully is kind of what I'm saying. But the data's there. We just need to figure out a way that we all share in that data in the right way.
Oh, right, Jeff. I mean, Netflix and Amazon probably knows way more about me than my physician does. But we feel real comfortable checking into a hotel on a business trip and logging into our Netflix account and going on Amazon Prime. But you ask about registries, people literally recoil. But these are barriers that, rather than, not to pick a pharma here, but don't bring in the same disease management programs you brought to me in the 1980s and 1990s and just call it digital today. That's not going to work.
Yeah. So that's a great point. And is it, maybe I'll throw a question back out. Is it the privacy issue because it is healthcare? Is that the reason why this is maybe not working? Because you're right. Every time you do a search on the internet, within 5 seconds, you have personalized ads popping up, on your phone or on your laptop or something that's, related to it. Again, it's all out there, but it doesn't seem like we're necessarily doing that in healthcare. And again, is it because it is healthcare and it's the privacy issue? But it shouldn't be any different than what we're seeing with, like you said, with websites and e-commerce. I mean, So
We need to break it down, Jeff, and that's where pharma again can help. We got to break. I mean, when I hear people testifying and saying like, "Well, people can get that information. If I go to the bank and cash a check, the teller knows exactly how much is in my bank account, and I trust that she's not going to run a banner up and down the street about how much money is in my checking account." And Amazon has a lot of my purchase history there. But I'm trusting that that's not going to get out there. I mean, it's me personally. Do I care? Whatever blood test I had done gets out there. If it can help make me better and offset my premiums, right? My family premiums lower, create rewards if I hit targets. That's why I have a Prime account, right? I want the rewards. I think it has to be looked at differently. And again, incentives. And you've asked 3 times about pharma. Let pharma help with this. Let pharma help us legislate with this. Explain it to those who are going to be creating those privacy rules.
There's another one of my soapbox, things I say all the time. Aligned incentives. Right now, healthcare has misaligned incentives. I know this isn't solvable, but technology and AI should, if done right, should help us align incentives. And that's a big barrier right now.
You've touched on a couple of things through this conversation that I think are interesting, and I'm going to start with you on this, Joe. But it's this changing in the management of the site of service that Marcus referenced earlier that I think is important, because that's been a trend in healthcare for 30, 40 years. Out of the hospital, the physician's office. Technology is now forcing into a less expensive site of service into the patient home. And we've talked about wearables and several other concepts that go through there. What is it about technology that's going to facilitate 2 parts? One is still that communication between patient and primary caregiver. But secondly, to round out the other key constituents in healthcare today, that the advisor, the pharmacist, the insurer, but also the caregiver as we go through this, because as we go home, we don't have the same conversations. So PROs and wearables are becoming more important. What are some of the key things, because you've touched on it, that you think are going to allow us to not only move to a less expensive site of service, but also improve healthcare?
Well, yeah, I mean, it's I don't know if that answers your question, but it's data portability and it's accessibility to that data. And we kind of touched on that, right? If, the hospital is, making a decision, they get discharged, and, now we're, that goes from inpatient now to the payer side. Do we know what happened on the inpatient side? We have claims, but it's that coordination of care is an issue. So, answers to that, again, whether it's a kind of a singular platform or, within our network, within our patients, we're able to tie that back together. These are not new issues. Transitions of care, site of care, channel management. Those are not new issues, but you're spot on. I wasn't really thinking it that way, but it's data portability. And it would be awesome if I could go into my system and understand exactly what's been going on with that patient from end to end. I'm going to make better decisions and have better interactions with that patient. The challenge is right now, I generally, for other reasons, like we've talked about, I don't have access to a lot of that data. So maybe that's where AI could help. If I can't get it because of legislation or privacy, maybe that's where AI can help. We at least model it based on, utilization, prior claims history, gaps in care, adherence, all that kind of stuff. Maybe that helps me plug some gaps where I have. Again, we're only as good as our data when we're making decisions and recommendations.
And I think the thing that I know where Jeff was trained, and I think he'll probably concur with this, is it even the right drug? Is it, that sort of right drug, right patient, right time, as corny as that may sound? I think a lot of times we're seeing extravagant polypharmacy right now. I think AI could create, again, handheld tools to coordinate that care. I think the site of care issue, again, comes down to benefit design. That poor patient sitting there and they have their family has a deductible, and, we even saw incentives in Medicare where, infused Remicade may have been cheaper for a Medicare patient than using self-administered drugs in Part D. And patients were, doing their own kitchen table math and self-selecting where drugs, or using a discount card instead of a funded benefit. I mean, it right now it's up to savvy patients, consumers to make those decisions. And these tools have to be in their hand while they're getting that care determined for them. And like you said, should that drug be infused in a physician's office, or should it be in a clinic across the street? We haven't given many vaccines in doctors' offices for a long time, right? I mean, we need to look at the site of delivery of care a lot differently. I think with this sort of last wave of baby boomers coming into Medicare, home health is going to become extremely important. Jeff was quoting cancer drugs earlier. When Jeff and I started out in managed care many decades ago, we weren't envisioning sending people $20,000 of pills in the mail. And I don't know if that's necessarily always the right thing to do, right? I mean, that's another care coordination issue that is new for us. I mean, care coordination used to be, a long-acting injectable for schizophrenia, or having to infuse somebody who had, hemophilia. Now it's self-administered oral drugs need care coordination. That's a big deal.
Let's go back to something you brought up, Jeff, right? And so I'm going to try and narrow this down to your sphere, because both of you guys are on the pharmacy side, right? So you have your set of data, and you do have big data on your side with regard to claims over time. You also brought up polypharmacy. Is there anything you think you can do with digital to affect patient care in the real time now, looking at claims, especially in that polypharmacy world where you might not have it or might not need it, and you can look at not just conflicts on your side effect prediction or adverse event prediction, but also benefits and support? What are you looking at there?
There's a lot of work being done by our IT team around, predicting adherence, predicting, a bunch of other things that you just mentioned. Maybe I don't know if this answers your question, but I want to, what you guys said made me think of something else, which is there's a lot of work going on right now with these buzzwords of population health and social determinants of health. So, in that last comment from Marcus in the last question, it made me think of that. So, they're fun to talk about. I've never seen a really good standard definition of what those things are, and I think even internally we don't know exactly what that means. But we generally know what it is. So, Bill, to your question, I think, that's where some of this is valuable. If, let's say, somebody goes into the hospital for an MI and they come out and, there's a choice of using a specialty med to treat something or a generic, maybe it's the trade-off, again, of understanding, maybe the education level, the, ethnicity issues, predicting adherence to medications, predicting the impact of the cost of that medication. Again, to Marcus's point of benefit issues and out of pocket. Can we put all that together to find a better, more likely successful path forward for putting a plan in place for that patient, given all of these other dynamics that are going on with the patient? And that's pretty cool to me. Again, if we, we can, so we're anyway, so Bill, we are working on that again through data that we have. But I think the cool thing is, the analytics of looking at that individual patient and looking at what's going on around them, putting all of that information together to put a better plan in place for them that fits their needs in terms of outcomes, side effects, affordability, cost, complexity, access to doctors, all that kind of stuff. So, Bill, I don't know if that answers your question or not, but that's it's pretty exciting. Again, it has to be done carefully. We've scratched the surface, but these types of modeling and data absolutely could fill in gaps that we don't have right now.
And what Jeff said to jump off there too is, the P&T committee process, the drug selection process, Jeff, I don't know, it really hasn't changed that much over the last 25, 30 years. It's still safety, efficacy, and cost. But what Jeff said is spot on is, and that's really exciting to me as well, is coordinating that benefit and coordinating that care is becoming extremely difficult. I mean, if you're looking at just metabolic health, I mean, we've got 25 drugs coming out. We got 3 different routes of administration. We've got folks who are going to be getting these drugs all over the spectrum, Medicare, Medicaid, commercial, right? And it's not going to be one size fits all. And, look what we do again with long-acting injectables with HIV. Look what we do with long-acting injectables in schizophrenia. I mean, there's a lot of case and care management that goes into that. So it's not, if Jeff and I just spent our time worried about the drug benefit or the pharmacy benefit, we'd be out of business, right? We're both having to look at this stuff much more holistically. I'm sure I'll speak for Jeff. Our clients depend on us, not just saying, okay, well, the pharmacy trend went down. It's got to be a healthcare trend. It's got to be an outcome trend, and it's got to be the total healthcare dollar.
Absolutely.
We're closing in on the last 5 minutes. This has gone too quickly. There's too many questions running through my mind right now, to be quite honest with you, as we've gone through this. And I'm not going to actually ask those questions, but I think they're for responses. But I think there's things like silos within the payer community. How can pharma help with that? You mentioned the fact that you had drug data, but you might not have medical data comprehensively in what you do, but this idea of data portability. So we've touched on that. We've touched on just what technology is doing in your processing power and all of this. So in this last 5 minutes, I'm going to ask each of you to kind of give a summary. What is the one or two things that if you could solve short term, that would make the most impact for you? What could happen in the short term from a pharma partnership or from a partnership anywhere that would make the most difference in your mind? So Jeff, let's start with you.
Well, I think the biggest one is, because again, I don't know what pharma can do to solve some of my internal data issues, because again, we have the claims, they're not treating the patient. They shouldn't even know that. But my issue is, can we get to a point where we legitimately have shared risk? And we are working together. I mean, we'll pay you for a drug that works, but if the drug doesn't work, then the question is, why do we or the employer have to bear the full risk of that? So it's better understanding the patient and the patient type, and what, based on data, what is theoretically going to work better than something else, and it's sharing risk. And right now, some of these outcomes are subjective. There's ways to get at that. But that's to me, until we solve the siloing shared risk issue between the payer and the pharmaceutical company, we're going to be at odds moving forward. And if we can solve that, then we can legitimately have partnerships.
Marcus?
Jeff's right. It's absolutely about shared risk, and it's agreeing on the metrics of that risk. It's understanding that people in healthcare from birth to death are going to experience probably no less than 20 different health insurance plans, PBMs, self-pay, self-funded. We see a ton of employers going self-funded, and they're not doing it so they can have, wide open formularies. They're doing it because they're concerned about cost controls. They're looking at limiting benefits, excluding things. So, that's an employer response to what's happening right now. So how can pharma help? I agree with Jeff. It's the shared risk, and there are people out in the environment. There's exceptional health economic, both private and public institutions that can help maybe ingest this AI technology, and maybe pharma could work legislatively to break these barriers down so we can have better access, obviously with right patient permissions and physician permissions to do this. I'd like to work with pharma figuring out ways so we can unburden our physician community and prescriber community so they're not spending 65% of their day, wallowing through the data, and we should have them seeing the patients. And again, probably everyone's at fault for that, right? Heaping more things on them is not the solution. My dream would be get to a place where we can put all of that in the patient's hand in the prescriber situation, so they could see, wow, we could move that into this benefit design, or we could move you to this site of care, or maybe it is better to have this done at the hospital, or maybe it's better to coordinate home health. I think it's not just the drug selection. I've been harping on this all the time. It's really coordinating the benefit and site of care. And again, pharma can help break some of these barriers down. If every pharma company acts in a silo independently, I hate to say it, I agree with Jeff 100% that we're not going to get there.
Yeah. And maybe I know we're running short on time. Maybe we can throw a question back out. I think there's this issue that's obvious. Well, I don't think. I mean, it's an issue that's developed over the years in terms of, net cost and rebates and everything else. And so, we kind of get blamed for escalating drug costs because, we require rebates. I think pharma and payers should be on the same page there. And I think we would we want to drive to cost effectiveness and low net cost and things like that. But there are other stakeholders that we haven't really addressed here, and we probably don't have time to address. And so whether it's brokers, consultants, providers, again, we all have misaligned sentences. So that, I think, to me, might be an opportunity to work with pharma in educating employers, but do it together in the right way. So we're not, again, giving mixed messages. We have to be on the same page. But then we can get away from rebate guarantees. We can get away from all these other things that are, escalating costs and negatively impacting accessibility and affordability and things like that. Because ultimately, end of the day, I do think pharma and payers are on the same page there on what we're trying to do. But there are, half a dozen other stakeholders that also have to be brought into this. But so I think that, again, there's an opportunity to, again, get away from these historical models. If we have better data and we can change the system when it comes to what is being rolled out to the patient via the consultants.
And my last comment there would be, again, that stop the finger pointing about who's the bad guy in the equation. If we don't solve this, it will get solved for us, and people will just go direct. Thank you so much.
That's perfect. Thank you so much for your time. I think you've raised more questions, which is perfect. That's exactly what I was hoping would happen here, because I don't think anybody's going to solve this in one 45-minute conversation. But if we can start asking the right questions and looking forward to a positive conversation, we can start to really make some differences out there for what's going on. So thank you again for your time, and look forward to continuing this conversation offline for many years to come.
Thank you.
Thank you.
Thanks, guys.